Hello, welcome to Neobiotech International Virtual Seminar. Thank you for attending this webinar, and my name is Gabriel Lee. I'm gonna be the host for today's webinar. We have 3 webinars remained at this moment. Today, Dr. Park is going to present about implant stability. Next week, Dr. Daniel Carcamo from Spain will be the speaker. He will present about GBR technique. The last week, as 26th day, Dr. Mauricio Prada from Chile will present about surgical solutions. Please remind 19th and 26th day, webinars will be in Spanish language. All right, for today's webinar, Dr. Park from USA will speak about how to measure implant stability. For 1 hour, he will share his experience and knowledge. Please use chat button to communicate with me about any issues other than topic. We will have a Q&A session after lecture, so please submit your question through Q&A button. Speaker may not answer for all questions because we have limited time to take all questions. If you have more questions or anything for discussion, you can contact Neobiotech website or Facebook page or by email address. Okay, now let's have Dr. Park to start. Please welcome Dr. Park. Hello, doctor. Are you there?
Yes, thank you for kind introduction. And instruction, Gabriel. All right, so let me start.
Okay, I'm gonna finish screen sharing.
Hello, everybody. My name is Dr. Park, and I lives in Los Angeles, California. Most of all, I'd like to appreciate all of you for your enthusiasm and then time to sharing with me, right? Again, welcome to Neobiotech International Virtual Webinar and Seminar 2. So today we're going to discuss about the stability of implant, right? Those implant stability makes me smile and also make me cry sometimes. So let me share what I learned and then what I faced in many situations. So let me start my presentation with you guys. Okay, so first topic is how to measure. Our title is how to measure the implant stabilities, right? First of all, I'd like to introduce myself. I used to teach in UCLA and prosthodontics for about 15 years, and then I began to work with Neobiotech and a couple of different companies. And at this point, I work as a director of the GAO USA and also R&D consultant of Neobiotech USA. And also this year I work as a president of Neobiotech USA. So first, the critical question for our clinician is when to load the dental implant. Yes, we place the implant and we want to know when to load the dental implant. In other words, when to have a crown. Patient always ask us to have an implant faster and faster, right? And then put me crown, let me chew earlier and earlier. So we really want to know whether my implant is ready to have a crown or not, right? So for those determining factors, we have patient. So what patient need, what patient want, and then compliance and occlusion, and also medical dental history. And also we need to look at the soft tissue, whether soft tissue around the implant is healed well and matured very well if we graft the soft tissue. And also hard tissue, that is bone, right? Whether those infection is gone and the remodeling is done and also integration is done. And also, last but not the least, implant stability. Those implant stability, we're going to discuss about it. Based on the 2008 article, I just singled out one sentence. What they're saying is achievement and maintenance of implant stability are prerequisite for successful clinical outcome. About 20 years ago, when I started a dental implant in my clinic, and then the stability is kind of optional, right? If you achieve the good stability is good, it's not that great, then put into sleep, right? And let's wait. However, in these days, we know that achievement and maintenance of stability is not optional. It's a prerequisite. So if you want to have a clinical outcome with a successful prognosis, then we must have those implant stabilities, right? But based on the JPD, their definition of the stability is those things. So when we measure the stability, first factor we have to think about is in the presence of the force. And second thing is stand or endure. So in other words, when we think about the stability, that means how much we can endure or how much my implant can stand against the forces. And also they also mentioned about the primary stability is a pure mechanical stabilizations. Let's take a look at the other definitions. Based on the American Academy of the Implant Dentistry, their definition of primary stability is an absence of clinically detectable implant mobility. Well, now they talk about the implant mobility. And also they also talk about the secondary stability is a biological engagement. So when we talk about the implant stability, we talk about the force and then the characteristic or capacity of endure against those force and also implant mobilities, right? So now let's talk about the implant mobility, because to measure the implant mobility is, in other words, measure the implant stability. Once we place the implant in patient's mouth, sometimes our implant is moving up and down. Oh my God. Well, sometimes once we place the implant, it can move left and right laterally. Not a great situation. Well, many times when we place the implant and patient begin to chew, maybe our implant is tilting like that. Or once we place the implant, and then it can be a spinner like that. So those four kind of situations that we faced every day in terms of the implant, the mobility. So to measure the implant mobility means that we want to measure how much our implant is moving patient's mouth, like this, all different kind of characteristic. In other words, to measuring those implant mobility means that measuring stability. So we have a high mobility, that means low stability. If we have a low mobility, that means we have high stabilities, right? So in my humble definition of implant stability is an absence of fixture mobility under the physiological force from the mastication. In other words, when we place the implant, when I put the crown, I want my patient chew. When patient chew, I hope my implant is not really moved, right? That is my humble definition of the implant stabilities. So far, we have learned about the implant stabilities like that. We all know about this, right? We have a primary stability and secondary stability, right? So when we have those crossover, they're gonna be the implant stability deep, and we call that is so-called dangerous zone. So this is what I learned when I was resident, and then this is what I've been taught my resident for the last 20 years. But is it really still true? In this day, we did a lot of immediate loading, and then also Neobiotech, we claim that anytime loading is also possible. So bottom line is those conventional stability pattern goes move to the new stability patterns over here. As you can see over here, what we try to move up our primary stability really high, and also secondary stability is quick in time going to be faster and faster. Is it possible? Well, based on my research, and then for the last 10 years, Neobiotech's research and of the effort, we believe that to have a better mechanical initial fixation, we have a good macro design, and then osteo size and design need to be proper. So in other words, non-invasive, the surgical protocol, so-called CMI fixation. And also, when we do that, we want to do the minimum damage on the bone. So minimum damage on the bone means that we have a less time needed for the healing and also integration. So to achieve the Neobiotech, we create those two, the concept. First one is CMI fixation, and the other one is anti-thermal damaging osteotomy. Unfortunately, I do not have enough time to share with you guys, but hopefully in the future, I can have another webinar with you guys and I can share with those the information and also clinical protocol with you very soon. Now, let's get back to the implant stability. We discussed about why the implant stability is really important, right? And then based on 2010 article, there is a couple of ways to measure the implant stability method. First one is basically destructive method. First one is tensional. As you can see on the diagram A, we place the implant, we push those implants laterally until it fractured out. So we can measure the strength of those implant stability. Well, once we place the implant, and as you can see on the diagram B, we can push out. So when it's pushed out, then we measure how much force we're using it. Well, sometimes we pull out those implants and then we measure the force that is needed, right? And also when we were young, in other words, when I was young, about 10 years ago, at the time, many people discuss about the reverse torque. We place the implant and then remove the implant and then measure the torque, right? That is also another way, right? And also, in the research setting, we discuss about the BAM, that is a value of actual micromotion. So actually this one is we measure the actual implant mobilities and movement in the research situation. However, those one is not possible, right? If we place the implant and pull out the implant, patient going to sue us, right? So that is not possible. Then at this point, what is available to us? Right? That is a non-invasive or non-destructive method. First one is sound. When I was a resident and my professor told me that, hey, tap the implant healing screw with the tail of your mirror and listen to the sound. If your implant is well also integrated, you're going to have a clear sound, right? But to me, to be honest with you, I cannot tell whether my watermelon is ripe or not by tapping it. So sound is very subjective. It's very difficult for us. The other one is the insertion torque. When we place the implant, we measure the insertion torque, right, or the final torque, and then we can measure the implant stability. Yes. And also the other one is the damping capacity analysis. Those damping capacity analysis is basically how fast your implant or your target is moving back once it hit it by the force. But I'm going to discuss it a little bit more. And also the other one is resonant frequency analysis. So let's go over a little bit more detail. But for our information, let's go a little bit of example about the invasive way. This is what I researched when I was in UCLA. At the time with the Neobiotech, we create a new SLA surface and we test it. This one is what we developed for the mini implant to place into the mouse femur. As you can see, those mini implant is placed in the mouse femur. This is the clinical pictures, right? And then we place those implant in the mouse femur and then we measure it. So 2 weeks, 3 weeks, and then once we cut it, and then as you can see on those middle pictures, I pushed out. When I pushed out at some point, the force is going to be dropped and bounce up. That is we call that as a break point, and then we measure the degree of the osseointegration. This is how we use for the clinical research in the animal situation to measure the implant stability or degree of osseointegration. But this one is not possible for human being. And also in terms of the VAM, value of actual micromotion, as you can see, we need a huge equipment. First one is, as you can see over here, there's an impact hammer, right? So once you place the implant on the solid object, and then you're going to check that with a laser beam. So once those are laser beam touching your implant, and then you hammering it. Once you hammer it and then hammering it and your implant begin to move, and then those laser mark going to measure how much it moves. So that's you can see on the right side. So this one is most accurate way so far. However, the problem is we cannot use this in the human being, right? Because there's too much equipment, and then we cannot bang the patient's mouth with a hammer like that, right? Then now what we can do in our clinic. First one is insertion torque, right? As you can see, I can use a manual insertion torque wrench, and also I can have those digital torque wrench, right? So now you can see when I'm using those digital torque wrench, and then I can record the high number of the torque, and then that I can measure it. So insertion torque is a torque measured continuously while the implant is inserted. What some people call that is a seating torque, so-called final torque value achieved when the implant is inserted, right? So nowadays, it is not really important. Usually, as a clinician, when we place the implant, we always measure the final moment of the torque, and then that we call that as the insertion torque or seating torque, right? So now, there is two different group in terms of the what is the torque is how much torque is adequate for the in our clinical situation. While some group they claim that they're going to be possibly compression necrosis, the other group says there is not actual the compression necrosis. So hopefully I can have more time with you guys with our CMI fixation new webinar, then I can go a little bit deeper and detail with you guys, right? But as a clinician, even though there has very different opinions, but we do not have to have a really high number. That is not necessarily high number of the torque in terms of our patient care, right? So usually 50 or 40, that is enough for us, right? We have no reason to get the 100 insertion torque, right? Now, let's talk about the resonant frequencies analysis, right? Those are very fancy word sounds with very complex. But actually what it is those the machine measure the vibrating of those the objects. For example, let's share those quick video clip. So as you can see, once I hit my wine glass, and then we can hear the sound. What really happens is when I hit the wine glass, my wine glass is vibrate. When it vibrates, it creates a specific frequency. In this case, those frequencies are hearable, so we can hear as a sound, right? So resonance frequency analysis, basically, this machine put the magnetic force on the implant using the smart pack, and then it creates the vibrating of the implant. So if the implant is vibrating, it's gonna create a specific frequency, then this machine captures the frequency and it converts its own unit, that is ISQ numbers, right? So this is how they measure it. But the problem is, based on my experience, clinical experience too, that when I'm using the Ostell machine or those ISQ machine for a long time, but especially in this situation, I found the problem. Let me share those video clip with you guys. In the middle one is a clinical situation. When I place the implant, as you can see, half is in the bone, half is on the air, as you can see over here. So we all know that this implant is really problematic. So I tried to mimic the situation in my research setup, and then this is how I did. So let's share. So I placed the implant, and then I put some smart pack, and I'm measuring the ISQ. 63 보이세요? 보이나요? Yeah. Now, as you can see, its number is like 61 and 63. That is a medium stability number. So they saying that even the early loading is possible. But as you can see over there, there's no stability at all, even though the number is really high, right? So then can we trust those RFA, those ISQ numbers, right? So I try to find out the reason, and now let me share why this is happening. What I did is I got those Play-Doh with my son. Now, As you can see, without the Play-Doh, it vibrates really well, and then we can hear the clear sound. But with a little Play-Doh, the vibrating compromise, and then the frequency going to be compromised, and as you can see, the total number is false positive. This is what really happened. So when we using those RFA, or resonant frequency analysis machine, we have to think about the defect pattern. So first one is, if our implant has a vertical defect, then it's going to give you a false positive, keep in mind, right? Now, let's talk about the horizontal defect. And also this experiment showing you that the effect of the graft material. So many times we place the implant right after pulling out the tooth, and there's gonna be big space around it, right? And then we put some bone graft about here, and then we do the restoration later on. So I try to find out the effect of the bone graft material on the RFA. So let me share those video clip with you guys. So first one on the, I'm using the cow rib, and then I do the osteotomy, and I intentionally make the over osteotomy, so create those very, very loose situation, right? As you can see, there is a gap between implant and the bone. And then as you can see over here, the torque is almost zero. There's nothing hold it. And then I measure the ISQ 28, right? 20, very low number, so far so good. So now I'm doing the cow bone graft, right? Auto bone graft over here, right? And then I place the pack and then measure it. Now you can see the numbers jumped, right? 22 up to the 48, right? In other words, did we increase the stability of those fixtures by putting the wet bone graft? Answer is no, right? There's nothing really holding. We know about that. But so as you can see over here, I just very easily remove the implant, right? But why this has happened? Because those bone graft, wet bone graft material gonna stuck around the implant surface, and then when those magnetic force try to vibrate it, and then the material, bone graft material, compromise those vibrating. So there's a less vibrating happen, then actually less the different frequency, then ISQ number going to be jumped up. So in other words, it's gonna create also false positive, those ISQ numbers. So in terms of the RFA, if you have a Ostell or penguin, those are really fine. However, keep in mind, those two situations, when you have a vertical defect, right, then you're going to have a high possibility to have a false positive one, as I can show you in the first experiment. And also, if you have a bone graft, and then your bone graft material give you a false positive in terms of implant stability issues. So keep in mind. And also the companies claim that they have a linear situation of implant stability and displacement. As you can see over here on the y-axis is implant stability, and then x-axis is displacement. So ISQ number is high, then displacement is low, and the ISQ number is low, then displacement is ISQ number is low, then displacement is high, as you can see over here, right? But when we look at more closely, let's look at those graph more closely. Same graph, and then as you can see over here, let's focus on that area, because that 50 and 150 micrometers is what really needed for us. If those displacement is 2,500 micrometers, that means 2.5 millimeters. We don't need to measure it. Once we place the implant, if our implant move about 2.5 millimeter, then there's no reason to measure those things. Even 2,000 micrometers, 1,050 micrometers, those are not really meaningful. What really meaningful to us is our visually not detectable range, that is about 50 and 150 micrometers movement, because those movement is a maximum movement that our osteoblast can also integrate it and proliferate on the surface of the implant, and then it can create the bone and ended up the osseointegration. So those 50 and 150 micrometers range is really critical. But when we look at those sample number over there, I can see only about 7 numbers, then I don't see any good linear relation over there. So whenever those company using their article. I'm not saying this article is wrong, but the way we interpret it, we have to be careful. In this case, there is not really clear relation between displacement and then implant stability, as you can see over here. Now, let's talk about the Periotest, damping capacity analysis, right? Measuring the damping capacity and the stiffness of the natural tooth or implant by measuring the contact time of taper after focusing the test surface. And they call that as a Periotest value, PTV. Then what they're saying is if the number is negative, it's a good. And if number is positive and the higher number is bad, right? So for the Periotest, less number is good, higher number is bad. So damping capacity analysis is basically once if you have an implant and you hit it, once you hit it, if your implant is very weak, and it's going to be knocked out and then coming back, right? So it's going to measuring that returning time once I hit it, and then it's gonna be move back and then come back. If those implant is really strong, and then when I hit it, it's going to be real little bit move back and then come back very quickly. So it going to measure, it is measuring those returning time or contacting times, right? The problem is, let me share the video clip using the Periotest. 6.1. 6.1. So as you can see over here, to measure the one time, you have to hit the 16 times. And also the force is quite big, 1.2 newtons, right? So if you want to measure the 3 times, then you have to hit the implant 48 times. And then patient really enjoy it, right? That is a really, really bad situation. So because of the sound and then the pain, so patient rejected it. So nobody want to have this one. And then also based on my humble research experience, and then those periotests also compromise actual implant stability issue, right? So doctor doesn't like it, and then patient doesn't like it. So this periotest still in the market, but nobody buy it except the people like me who did the research, right? So I do not recommend to use it, right? Because in clinical situation, it is very difficult to use it. However, in terms of those, the accuracy of this machine is if I using in the research, the environment and everything is controlled, then actually this is a great machine because it is not measuring vibrating because it is actually hit and then it's going to measure the movement of those target with the contacting time. So it is, in a way, direct measurement. So that is a value in it, right? So it is a great machine to measure the lateral mobility of that target implant or tooth, right? But not in a clinical situation. So about 5 years ago, Neobiotech revisited those damping capacity analysis and then they improved a lot. So they decreased the amount of the force about 30%, 0.9 Newton, and then instead of the 16 times hitting, it changed into the 2 to 6 times per measurement. And also it has a very good protective function on it. So why I put in the 2 to 6 times, if we measure it and then the measuring number is more than 60, then it's going to hit the 6 times. But if those number, the stability is not good, then it's going to hit only 2 times and stop it. So because we want to protect the patient and implant too. So let me show those video clip. This is a Neobiotech NHX situation. 61. You can see 61, 6 times. 59. 59, 2 times. 59. 59, 2 times. Because I work really hard to capture those moments. So this machine is quite sensitive. So if those number is more than 60, it hits 6 times. But if those number is below 60, it only 2 times. So then we can protect those fixtures, as you can see. And also, as you can see over here, if the implant is totally dislodged, then as you can saw on the previous slide, and then it's going to give you those red bar and also those yellow bar, kind of warning you about that. So now with all those instruments, and then I try to find out that what is the more reliable or validate instrument that we can use to measure the implant stability in our clinical situation. So I'm using the fresh cow rib, and then each cow rib by taking the micro CT, I make sure those cortical thicknesses of 1.15 millimeters, and those the situation with the bone block, and then I did the place the implant and measuring the implant stability with the different machines. So the total number was 275 numbers, the samples, and then I tried to measure which implant stability machine is more reliable. In other words, I'm using those four different way. First one is a torque, measuring the torque, and the other one is resonance frequency analysis, and the other one is damping couples analysis, and then finally I'm using the micro CT. So by using the different osteotomy size, and then I create the different torque, right? As you can see from here, from the 5.7 to about 63. And then I measure in this case, in each case, I measure the resonance frequency and also damping couples analysis with the numbers too, right? So I try to find out whether all those the different machines shows the same pattern or they are conflict each other's, right? So this is what I do. First one is I'm place the implant, and then I'm measuring the torque, and also I'm measuring the ISQ with the four-way, and also I measure the NHL, I measure the Periotest, right? As you can see on the different samples, right? This is, I'm showing here that I'm measuring the ISQ with the Ostell machine over here. And also this is, again, Periotest, and this is 6.1. 61. Right, so with those four machines, and also I'm using the clinical data, so on my patient, and then I try to gather it as much as possible. So let me share briefly about the result. So first one is I want to see the correlation between Ostell ISQ machine and insertion torque over here. So as you can see over here, it was a very difficult graph. Difficult graph means that it was not easy to find out the correlation between those two values, right? So the regression, the correlation number was basically 0.5. Our number is 0.5. That means if the Ostell number is the increase, and then the insertion torque going to be increased with less than 25% possibility. So that means if the Ostell machine increase and we expect the insertion torque is increased, that's going to happen only 25%. So that is quite not acceptable in terms of clinical situation. So no matter how hard I try, I couldn't find out a good correlation between those two, but it ended up I look at, and then I find out some threshold patterns over here. So for example, over here, I'm using the 15 Newton insertion torque. That is the threshold, minimum threshold. And also I'm using the 60 ISQ numbers. So as you can see over here, 96% of a sample with a greater than 15 Newton insertion torque has more than 60 ISQ. And also 83% of a sample with a higher than 60 ISQ shows more than 15 Newton centimeter insertion torque. So this means that in other words like that. If you measure the sample, and then that is amount that has a more than 60 ISQ, and then you have a torque above the 15 Newton centimeter. In this case, the common area between those two is the torque has more the common areas. That means if I have to choose which one is more safe in terms of the clinical situation, yes, torque has a more common area. So when I compare those two, then I choose the insertion torque as my stability numbers. So for safety reason. This case, I'm looking at the Periotest and insertion torque number over here, right? This situation is a little bit better, about 36% can be correlated, right? But in terms of the threshold theory, right, about 91% is more than 15 Newton centimeter, has a less than 5 PTB, and also 96% is smaller than 5 PTB, has a more than 15 Newton centimeters. In other words, it was like that. Periotest value less than 5 PTB, and also insertion torque less than 15 Newton, then it's going to be like that. So in the research situation, Periotest is safer than torque because it has a more common area. The only problem is this is only research setting situations, right? Now let's look at the correlation between any check and insertion torque over here, right over here. And in this case, the regression number is about 0.7. So that means about 60% or about 50%, we have a chance that any check increase and insertion torque is increased. So this number is still not good enough, even though in terms of statistics, it's a strong positive correlation, but in clinical situation, 50% is correlated. That is not really great number. In other words, if the any check is higher, then insertion torque is higher with a half and half possibility, that is not that great. However, when I look at those threshold theory, and then I realize it like that. So once we measure the implant stability with the any check, it has a 60 IST, and then we measure the insertion torque when we compare it, and then any check is inside of the torque 15 Newton centimeters. In this case, any check is quite reliable and then almost same as a torque over here. In this case, I'm comparing those any check and Periotest over here. Then this one is definitely because they are using the same concept, because both of them are damping capacity analysis. So their relation number is quite high, 0.9. That means about 90% is a possibility that Periotest is increasing and any check is increasing. In this case, decreasing, because Periotest is a negative number, is the better situation, right, over here. So in this situation, any check and then Periotest, and then more common area is any check over here, as you can see. So the overall, the bottom line is this: I am measuring those insertion torque and then the Ostell, any check, Periotest, and try to find out the golden tool that we can rely on it. But unfortunately, I cannot find any single instrument that satisfies those common areas. However, what I realize is if I using the two machine, it has a much better, right? So for example, if I'm using the AnyCheck, that is a 60 IST, and then insertion torque is more than 15 Newton centimeters, right? So if your implant shows that more than 15 Newton centimeters insertion torque and 60 IST AnyCheck numbers, then those samples showing that the average about insertion torque is 44 Newton centimeter, and Ostell number is 74, and then Periotest is 0.5, and ENG number is 67. So that's why I'm the claim that those threshold, based on those threshold theory, we have to measure the two different methods to measuring it. But what is really important is insertion torque, right? Why this insertion torque is important? Because insertion torque is basic. We do not have to spend another time and then another money on it, right? But insertion torque is basically spinning. The movement is measuring the spinning of that fixtures, right? So at this point, no other machine, any check, as I showed before, any check, or even the Ostell machine or Periotest, none of them showing you the exact value of those spinning. So those spinning situation, rotational mobility of the implant cannot be measured by any machine except the torque range. Please keep in mind, right? So whether you are using the Periotest, whether you are using the Ostell, whether you are even using the AnyCheck, this machine will not tell you the rotational, the stability of your implant at all. So you must measure the insertion torque, right? And then if you measure the insertion torque, and then if the number is more than 20 Newton centimeters, right? And then you measure the AnyCheck, that number is a 65 IST. So 20 and 65 IST, then I can tell you that you have a minimum requirement of the immediate loading, right? That means your implant stability is quite good. I can tell you that. Then how about this? if you already placed the implant, then patient come back later on, was the other doctors place the implant, and then 3 months later, patient visit your office, and you want to know whether you can put the crown on or not, right? My humble suggestion is this. In that case, we cannot measure the insertion torque because implant is already placed. But I strongly recommend you to use the reverse torque. That is a 15 Newton centimeters. So I strongly recommend you to removing the healing cap and then healing the abutment and then put some of the driver on it and then apply the reverse torque. That is only 15 Newton centimeter. Do not apply more than that. So if you apply the 15 Newton centimeter of the reverse torque and then you don't see any movement of your fixture, then first your bottom line is done. And then you place the healing abutment and then measure the any check, and then if that number is more than 65 IST, then you are good to go, right? So some people believe that 20 Newton is reverse torque, that is too much. And then some people really worried about apply the reverse torque on your implant. However, think about this way. When we tighten up our implant with a temporary abutment, that is about 15 Newton, and then final abutment we usually apply about 30 to 35 Newton centimeters. So those 15 Newton centimeters reverse torque is actual very minimum. So if your implant is moving with a 15 Newton reverse torque force, then you really do not want to put any crown on whatsoever. So this is a kind of precautionary tool. So once reverse torque is done, your fixture is moved or spin, then how going to handle that situation, that is depend on your clinical situation. Some doctors place a little bit deeper, while the torque is really bad, then you have to remove the implant, put the new implant back. So basically that is a depend on clinical situation, but applying the reverse torque is one good way to prevent any future catastrophic result, right? Our catastrophic result is basically 3 months later, patient comes in, we put the crown on it, and a couple of days later, patient come back with a crown and implant on their hand, right? We do not want that happen, right? So I strongly recommend those reverse torque and any check with 15 and 65. That is the great number that tell you that your implant is ready to put the crown on it, right? That is end, keep in mind, okay? Now, there's an additional usage of damping complex analysis machine like AnyCheck and then Periotest. So as you can see over here, when my patient comes in and place those two abutments, looks like fine, but I didn't pay attention to it, right? However, once I take the impression and when I put the crown on it, it doesn't fit, right? So that was really, really disappointing. So what really happened is when I put those healing, the stock abutment, actually, as you can see over here, the stock abutment is not really tightened up, not well connected, right? In this situation, what you can do is, once you place those abutment, and then you can using the AnyCheck, and then you can check those stability. So usually, as you can see over here, so if you have a crown screw loosening or the connection is not correct, then it's going to tell you exactly and immediately that your connection is not really great because your AnyCheck value is dropped. This is a more clinical case. So one of my residents placed those crown on it, and then he measured those AnyCheck situation. So before put the crown on it with a healing abutment, he measured the IST number that was a 76. That's a good number. And then he put the crown on it and then 35 Newton tightening and measured the IST, AnyCheck number, it was a 60. So I find out a big drop off from 76 to 60. So I asked my resident, take the crown out and then check the proximal contact again and then put the crown back. Then it's going to move up 72 IST. So this is another good example. How can we use for those AnyCheck, not only for measure the implant stability, but also to measure the proper connection between implant and then prosthetic component, right? That's another good way. Then how can we use the any check, for example? In this situation, our clinical situation, all we need to do is place the healing abutment, right? If I'm using the Ostell, we remove the healing abutment, we put the smart peg on it, and then measure it, and remove the smart peg on it, remove smart peg, and then put the healing abutment back. But in terms of the inconvenience, if you're using the anycheck, you don't have to worry about it. Just place the healing abutment, and then when patient come back, and then clean up around the healing abutment, tighten up with your fingers, and then just measure it. So all you need to do is you have to choose the proper healing abutment. No matter what implant system we are using, it doesn't matter, right? All you need to do is choose the proper healing abutment. That means about 2 millimeter above the gum. That's all we need, right? So in the pictures over here, visual portion is a very little number of those space. However, buccal area has a quite a good space, so about 2 millimeter. That is enough. So you don't have to have a 360-degree 2 millimeters. If you have a 2 millimeter space on the buccal area, excuse me, buccal area or lingual area, that is more than enough. Like that. So now, in other words, so if sometimes your gum is parallel to your healing abutment, then you're going to measure the stability by perpendicular position like that. That is a great way. Sometimes our gum is not really parallel to our healing abutment. So as I showed in the previous the clinical pictures, medial is high, distal is low. In this case, no problem. You can just measure it. So what I found is mucosa height doesn't affect the mobility number of the checks like that. So sometimes we place the healing abutment. Unfortunately, our healing abutment is a little bit low, so we have only 1 millimeter height, then you cannot measure the perpendicular. In this case, about 30 degree, you still measure the angle measurement as here. You can measure like that. However, if your gum is too high and then you hardly see the healing abutment, then you have to replace healing abutment. But what I found is if you angle the measurement, as you can see on these the pictures, right, then it's going to give you about 5 to 9% of a higher number because the damping capacity basically hitting the target or perpendicularly moving it. But if we're hitting the target with the diagonally, then they're gonna less movement going to be happen. That's why when you using those angle measurement method, then make sure about 10% is subtract. So for example, you measure with the IST and then its number is 80 with the angled measurement, then your actual number is about 72. That is a more safe way. So once you measure those angled measurement, then whole way you're going to measure angled like that. Okay. So the suggested protocol for the any check. So there we have some the learning curve for proper measurement. But once you measure about 2 to 3 times, then you know how to measure it, right? Bottom line is you have to hold your hands the steady and then you just push the button. So basically I recommend you to measure the 2 times. And then if those difference is less than 5 ISC numbers, then the average is your numbers. But if the difference is more than 5 ST, then measure the third time, then about more than 99% those number going to 2 out of 3 going to be very close to each other. So then that is your numbers. But one thing you have to remember this, I told you many times, what is the most important number? Torque, right? So if your torque is less than 10 Newton centimeters, then forget it. You have no reason to measure the stability with a different machine, right? Anycheck, Ostell, Periotest, Penguin, forget it. It's already not that great. So if your implant insertion torque is less than 10 Newton centimeter, leave it alone. If your implant is a spinner, leave it alone. Bouncer, leave it alone. And also, if you do the bone graft side, then don't do that. So when you want to measure the implant stability, if you need the bone graft, make sure you measure the implant stability before the bone graft. Once you place the bone graft, do not measure it, including the NHA or including the ophthalmology, because when you are doing it vibrating or it hitting, and then your graft material are going to be scattered and they're going to be detached away from those implant surface. So don't do that. right? So in that case, you definitely consider the two-stage surgery and then have a more healing time. Or you wanna you wanna place the different implant like longer or the wider implant. That is your clinical situations, right? So overall, when I consider all those factors in terms of whether I can measure the torque, whether I can measure the lateral mobility, whether I have a wrong bone graft effect, and in terms of the patient comfort, and then whether I have to pay extra cost and also our clinicians' convenience. When I consider all those factors, then what I realize it, right? NHA is excellent for the lateral mobility. Bone graft effect has no effect, and the patient comfort, that is acceptable. And also, a good thing is if we do the Ostell, I do not have to remove the healing abutment, put the smart pack again, and then measure it, remove the smart pack, and then put the healing abutment back. And also, when we think about the extra cost, those smart pack for the Ostell is about $20 if you about $20 to $50, depending on situation, right? That is quite expensive, and then also it is not possible to autoclave it. So all you need to do is a cold sterilization, or you have to use a new the smart pack. So that is quite difficult, right? However, again, all those machines cannot measure the torque, that rotational mobility, only torque range. That is what we need. So my suggestion is if you want to measure the implant stability more safe way, then I strongly recommend for the NHA and also the torque. So if you do not have any the stability measuring machine, then NHA is my recommendation. However, you already have a Ostell machine. Well, you already have a Periotest, right? Then using that with your torque, right? However, in terms of Periotest, be very careful because it's going to also destruct those osteogradation itself, right? So again, always focus on the torque, insertion torque, right? Or using the reverse torque, and then use any check to compensate and then to measure the lateral mobility or vertical mobility. That is a great way to make sure your clinical result is always the good way, right? All right, that is what I prepared for you today. And then I'm going to get the questions from you guys. So Gabriel, could you take over?
Yes, thank you very much for the lecture. And if any of attendees have a question, please use Q&A box. And if we don't have any question, we're gonna finish the lecture, and I'm gonna notify some of the lectures. Okay, then let me start the share screen. Okay, again, thank you very much for the lecture, Dr. Park. It was very awesome and nice lecture. We'd like to ask some feedback from attendees about today's webinar. There will be an extra pop-up screen with 5 questions. So please share 1 minute for us. Will be only 5 questions. It won't take long. So we're gonna always try the best to improve the quality of webinar for your satisfaction. This lecture will be uploaded in our website with a YouTube video, so you can watch again this lecture later at any time. Please stay connected with Neobiotech social media to communicate with us more. Search Neobiotech in Facebook and YouTube, then do like, subscribe to get more information. For the next upcoming webinar, it will be on 19th, next Wednesday. Dr. Daniel Carcamo from Spain will give the lecture, The title will be Bridge Expansion or Split Class Technique in Spanish. Please remind that we do not have a translation service. If you have any questions or information needed, please contact us by email address. And don't forget, you can get more information in our website and social network service. Thank you very much for attending our webinar today. We hope all of you enjoyed this time. Please have a good day or good night. See all of you again sooner. Thank you and bye-bye.